I find to use it very seldomly. There are very few cases. If you have a case that like it's the corneal opacity is too bad, I'd rather use a corneal prosthesis and do a better surgery than the ones that you can do with the endoscopic surgery. That's my opinion. So I use it very rarely, but I
Yeah,
still have it works.
yeah. The point is not very easy to use. It also you have
Yes.
to get some orientation. Sometimes you get lost. It's not very easy. And if you do not use it often, you do not get used to it. You just and you don't like. I usually do as you do. I put a ceratoprotez and do the surgery. And besides that, you do not have stereopsy. You do not have 3D. But it seems that has some advantage. I saw some cases of Flavio Rezende showing that you can better understand the traction in the ciliary body. Because when you depress, the traction just disappear and you don't see it anymore. So it may be useful, but also for seeing the placement of an implant that we like Yamani
Mhm.
intraocular that may be useful to. In some cases, may be nice to see. Sometimes we have blood, recurrent blood in vitreous, and we don't know what's this blood coming from. And you look everywhere in the retina and you see nothing. And sometimes it's behind the iris or in the ciliary body and in the past plicata of ciliary body, and we can't see in vitrectomy behind, just behind iris. So in some cases, I think may be useful. I would enjoy if the new machines come with endoscopy, and would be nice, I think. But it seems that they do not, they are not going to bring it in the new Alcon machine, for instance.
That would be a great idea. And
Yeah,
as we were talking about fluoroscopic vitrectomy, I wanna welcome Alan Franklin and Andreas Di Luciano.
Hi.
Hi, Alan
Hi,
Franklin. We're
friends.
discussing
Hi.
here about the fluoroscopic vitrectomy. We had a meeting some months ago about that, and I see that only a few centers they uh, keep doing, very much of fluoroscopic vitrectomy. And how you manage to do that nowadays? Are you doing much?
For me, I'm doing a fair amount of I'm doing more angiography than the fluoroscopic vitrectomy portion of it. With the um, with the 3D camera and a little bit of enhancement boosting blue color, I feel like I can see the vitreous fairly well. But I do think there's some role in fluoroscopic vitrectomy and detachments and as Andre was talking about, uh, the times where you need to get the vitreous out a little more anterior. I think that you can see it a little better with that, and then occult retinal breaks, you can see the fluorescein wafting through the break. So I think there's certainly um, use for it. Joaquin Sosa Lockwood, he's going to talk about it. We're doing a Retina World Congress webinar on August 10th in the morning U.S. time, and he's going to talk more about fluoroscopic vitrectomy. And Lukan Mishev, who's kind of pioneered it, he's going to talk about it. The angiography, we've got a paper coming out. Um, with Maria Baracol and Joaquin and Nas Abrio, where our post-op vitreous hemorrhage rates in diabetics are improved doing the angiography. Mainly once we peel everything, oftentimes we'll see little focal areas of hotspot leakage, or we'll see occult neovascularization that you just can't see without the angiography, and we'll treat that with laser. And our vitreous hemorrhage rate has gone down, and it's fairly significant. Um,
Yes,
so
and sometimes instead of just doing a PRP all over, and if you see the leakage, so I saw some videos, and you do some injections in the beginning of the case, and as you proceed the case, you keep doing it.
yeah, sometimes it'll help if the neovascularization is very fibrotic and old. I don't know that it helps a whole lot, but if it's even after Avastin, the little pegs of neovascularization, you can see them really well with angiography, and you can see, as we all know, we're tugging on one area and then another area over there. You start to see traction. With the angiography, you can see the mesh-like neovascularization and the extent of it really well. And it's white neovascularization against the dark background of the retina, so the contrast is really high. So operating in black and white doesn't bother you, I find it helpful in some cases to
Yeah,
do
yeah,
so.
very good. And so we are starting with you, Alan. Frankly, we are in different zones, so people are popping up here from elsewhere, from India, from Middle East, and they keep coming. They have different the timing, and we're going to be recording this and present it to the Retinawesome Retinal Videos channel. So we chose this time the subject of trauma. So we all separated interesting cases, mine included, for trauma. And I want to know whether you have your case handy, you want me to display it, or you prefer, as a keynote speaker that you are, if you want to present the case from your place. So I've got here the cases that you sent me. So
Uh, um,
sure,
if you want to go ahead and um, run the video, that's fine. I'm happy to do that.
sure. So let me just
And I really appreciate you having me. It's a big honor to work with you again. Thank
yeah,
you.
I know you've got lots of experience, and since you deal with so many subspecialties in not only retina, and these cases of trauma, they really make us very keen at learning different techniques, from each other. This is what matters most. So let me share here the just a second. Yeah, that's your case. Can you see it displayed?
Yes,
Should I start it?
sure, sure. Yeah, so yeah, I think this is the okay, yeah, this is the first eye. This guy was bilateral intraocular foreign bodies. It was a gas pipe injury, and you can see they're conjunctival and corneal foreign bodies. And so we had to dissect the iris off the pupil, did a bit of a capsulorhexis and got the lens in, and then took the rest of the traumatic cataract out. And then as we're doing the vitrectomy, we can see that the vitreous is organized um, kind of in the infratemporal macula, and typically that means there's something underneath it. And sure enough, as we're debulking the vitreous, there appears to be an impact site posteriorly, but there's another one peripherally. So the posterior impact site, we're getting what we can out of it, and then doing a choroidectomy. And really, the trick of this is trying to prevent macular dragging. So we do an ILM peel, and then we're actually reflecting some ILM back. Now we've got the foreign body, and you just want to make sure your sclerotomy is bigger than you think you need it to be to get the foreign body out. We stitch the sclerotomy. And so what I decided to do was to do a patch graft over that area, similar to a large macular hole. We get the patch graft, and then just kind of as belt buckle and suspenders, we'd preserve the ILM flap, and we're pulling the ILM over the patch graft, and then ultimately we left this patient under perfluoron for 2 weeks, and then exchanged it for a gas bubble, and he did well. That's the patch graft in place. He's got a bit of a foveal reflex and recovered 20/30 vision.
Wow, this is a beautiful post-op picture, and interestingly, I never seen anybody put a patch graft over the location of the trauma and then cover with the ILM. What is the rationale for that?
That just maybe I'm paranoid that it would slip. So that's why I did that.
Osvaldo, interesting case, and would like to comment on Alan Franklin's case.
I found it a very beautiful case. Congratulations, Alan. I think the rationale there is, if you cover the lesion, perhaps you're going to have less RPE cells over the retina and perhaps decrease the formation of an epiretinal membrane and macular traction. I would very much like to know how did this case go a long time, if the macula stayed like this or any traction formed, because these are very rare lesions, and I think you did an awesome job, great for Retinawesome, really Retinawesome, like Hudson likes to call the session. And how did this case go in the follow-up?
So far he's about 3 months out. He's retained 20/30 vision, and we've not seen any macular dragging. So hopefully
Awesome.
he's at the 3 month
Congratulations.
point. Thank you.
Yeah, interesting case. Let me display the other one. Just close this window here. Andreas de Luciano, do you want to comment on such interesting case?
Yes, an amazing case. Congratulations, Helen. I have one question for you, my friend. For example, in these cases, do you use like intravitreal methotrexate or any other anti-metabolic substance?
That's a really good question. I do in these cases. Um, and This guy was actually very touchy, and he was intolerant to methotrexate, so and to any intravitreal injection. But typically, I use intravitreal methotrexate in these, and um, we found it to be helpful in these, and we've actually found it to be helpful in our diabetics also. So yeah,
Yeah.
I'm using a fair amount of it. It appears safe and helpful.
Yeah, very good question, Andreas. And our friend Marcelo Murilo Sassamoto has a receipt for the methotrexate as well. So you're still doing much, Marcelo?
Yes, yes, a lot. Usually, what we do in these cases of retinal detachment is you know, work like 6 months, like this and I mean, the results are very good, and I'm still doing Hudson.
And how long do you guys use the methotrexate after the surgery? Because there's a lot of different like protocols where you can use it like once every, for example, 6 or 8 weeks. I don't know if you have any like unique way to treat these patients in the post-ops. For example, I use it when I have it, when it's available, every like 6 weeks for maybe four periods of time, and then I control with the OCT and retinography to see if there is any proliferation in the retina.
Is that uh, I think what you mentioned is is really poignant. As everybody knows, the initial protocol was 13 weekly injections, and I think there are a number of groups that found that you can get by with less injections than that. Um, and we, I'd love to have a panel at one of the meetings to kind of go over everybody's protocol and see the results. I'm doing 4 or 5 injections over 3 months, and I got that protocol from Chris Riemann, who I think is a really talented guy, and I modified that. I know some people that have gotten really good results that you mentioned with every 6 week injections for 3 to 4 months, so it's more like 3 injections rather than 4 or 5. So I think 12 or 13 is probably more than you need, but whether uh, 3 is the magic number or 4 or 5 is the magic number, I don't think we know. And I think it behooves us to try to figure that out.
Yeah. And going on with another case of yours, uh, Helen,
Sure. So
I
this was a little more straightforward, if you can call these cases. This was the this was the second eye. So this guy came to me, and so yeah, this was the other eye. This was sent to us a little over a week and a half after the injury. So I was kind of outside the window of infection. So we staged this. We did one eye, and then a week later we did the second eye. And similar thing, we're getting the lens out, and we've preserved some capsules so that we can get a sulcus lens in. And it's single impact site. The thing that really I think is helpful with the 3D surgery is, as I was mentioning, you can see the vitreous better. You've got more magnification, and then the data fusion up to the left, you can look at the flow, and if you're don't have any flow, you're in vitreous. And rarely we don't need to stay making PVDs very often at all because of this. And it's very efficient to make a PVD. And similar to the other eye, we enlarged the sclerotomy to get the foreign body out. Then we sutured the enlarged sclerotomy. We're doing some shaving of the vitreous base, and then um, we laser around the impact site. And fortunately, the impact site, as we can see, is mid-peripheral. I do 360 of peripheral PRP on these cases, and this was just an air fluid exchange. And this eye, fortunately, is done well also. And he regained 20/25 vision in this eye. So it's 20/30 OD, 20/25 OS. So I think he had a happy ending.
wow, these are great cases from the same patient. So
Same patient,
you
yeah.
did, and how? When did you do the cases? You did one case in 1 week, another week the other case, or a month later?
The other case a week later, and then to take the perfluorine out of the first eye, I did it a week after this. So the perfluorine was in the first eye for 2 weeks. So
But
we
yeah,
did.
another interesting thing is that in the first case, you peeled the ILM, and so you left the ILM there, and then you cover it. So this is interesting to do, but not very many cases that you get this ILM handy. But would you insist in looking after the ILM to cover the trauma place, the location of the perforation, or that's not so important?
I don't think it's so important. I was just able to do it relatively easily here, but I don't think it's so important. I mean, our experience, Flavio has a great experience with the large macular holes and grafts, and I don't think he covers them with ILM, and he gets great results. It was just something that I happened to have handy, and I figured I'd try it.
Andreas, and Luciano, would you like to comment on this second case?
Yeah, I was wondering the same
Yeah.
as Hudson. How do you maybe why, or if you try another different way to cover, for example, the defects in the retina, for example, with another membrane, like synthetic, like amniotic membrane or something different. Have you tried before?
I've not tried that. On this one, it didn't look like the retinal defect was all that large. And it was mid-peripheral, so I didn't think there was going to be a high risk of macular dragging, and without a big full thickness defect, I thought the risk of uh, PVR was at least smaller. But yeah, I think it's a really good thought to cover it with with you can do an amniotic membrane, as you know. You can also do uh, tenons. You could put tenons in there.
Or pericardium. I think there is also some studies using pericardium.
Sure.
Alan, could you tell us about any tricks and tips to how you manage to the graft to get the donation side to cover the whole how to manage to not to get much hemorrhage and make it safer.
I think for the for the graft, I put in a subretinal cannula to make a small bubble in the retina so that I wouldn't be traumatizing the choroid as much harvesting it. So that's one little trick. Another is it's kind of like making the sclerotomy to remove the foreign body. Always, I try to make it bigger than I think I need to on the donor site, because if you lose a little tissue or something happens, or you've got a little extra tissue to play with, and so you want to. So I try to oversize the graft a little bit, and then having it to the point where it's just about ready to fall off. If it's 360 degrees, uh, make your cut 320 to 330 degrees, and then make sure you've got perfluoron in so that you can just gently pull the graft off and slide it in the perfluoron to the site. Is that if you try to get that piece off and you're in aqueous fluid, it oftentimes will just fold up and become very unwieldy to deal with.
Oh yeah, good comments. And what is the make of the cannula you use? You use a metal one or any other one?
Um, I think no, mine is I think we get it from Dork. It's a Dewano cannula. I can look that up.
Okay, that's fine. So very interesting cases and how you managed that. And we could probably think the outcome would be bad, but the outcome was so good. And any cornea opacities afterwards, how did you deal with that? Did you get a cornea specialist? It was possible to do anything about the cornea or any laser to make it clearer, or it just healed on its own?
You know, the corneal foreign bodies, the ones that were very superficial, I took out, and then we did refer this patient to a cornea specialist to put him in a large diameter contact lens, and he felt like that. the foreign bodies uh, in the cornea are relatively inert, and oftentimes they'll slowly migrate to the surface and then come off. So he did not recommend an extensive removal of the foreign bodies. He felt like that would cause scarring. So yes, we just did a large diameter contact lens for most of these and some time. And the patient had a fair amount of discomfort, and he had a filamentary keratitis prior to placement of the contact lens. And once he had the contact lenses on for about a month, he was a lot more comfortable and got out of the contact lenses and is doing well.
Yeah, thank you very much for showing those cases. And I wanna ask Osvaldo, you have your case for presentation ready?
Yes, sir. Let me share the screen with you. Hmm. You got it? Can you see it?
Yes.
Yeah.
Yes, my friend, very
So
really
let me
impacting.
let me tell you just a small introduction about this case.
It is displayed. I can't see
It's
it yet.
there? Can you see? No?
I think you didn't share yet.
Sharing.
Oh yeah?
Yeah, yeah,
I
it's
can
good.
see.
I
Everybody
can
I
see?
can
see.
You
see it
cannot,
as
Hudson?
well. Very,
Very
very clear.
dramatic case. Very dramatic case.
Hudson, would you like me to go out and in again? I don't know why you're not seeing.
Oh yeah, please. I think
So I'm going
the second
to
screen
stop
is not displaying as well.
and let me go again. Share.
Oh yeah, no. It's wow.
Yeah.
Interesting, very interesting.
Can you see now?
Yeah, yeah, yeah.
Okay. So this is a 11-year-old boy. This is one of those days, you remember where you were, what you're doing, everything that happened that day when they called me from the emergency room and said, there's a intraocular foreign body here. I said, okay, I'm in the middle of something here. You can send to the OR. I can start the surgery. Then the doctor that was in the OR said, no, please come here. You do not understand what's going on. And then there was this boy. He was 11 years old. He was playing with a friend at school, and his friend stretched this elastic band, and the elastic band went into his eye. So what you're seeing on the pictures outside is the other side of the band. So this is what, looking at the other side, what we thought we were going to find inside the eye. So let me show you how I managed this case. So this already under sedation in the OR, how the eye looked, and this is how we did the surgery. So first, like opening the eye, the eye was really hypotenuse, and the elastic band, I tried to move it to see what was going on. But of course, the way it entered straight, it would not come out. Like a kid, when the kid puts the head through a chair and gets stuck there. So this is the clinical picture that I found, and I thought, what can I do to remove this thing from the eye? And the way that I thought it would be more useful was, like opening through the cornea, because the cornea is a tissue that eventually we can replace, right? So after opening the cornea a little bit, we could remove that metal thing from inside the eye, and then it's just suturing the cornea, and then it's another point of the surgery. We stop there, the eye's closed, or like we get more courageous now that we could close the eye and go inside, see like what we're going to find there, what happened to the eye. And I decided that we are already there. The kid is under general anesthesia, let's go for a vitrectomy, So first in the anterior segment, we started cleaning. Of course, the view was not very good in the beginning, lots of blood. You're going to see lots of lens fragments as well as the metal thing went into the eye, like destroyed the lens. But as we cleaned up, we are going to see that the boy was actually really lucky, as the point that touched the retina was nasal to the optic nerve. The macula was preserved. The eye had some retinal folds because of the hypotony. So I did laser over the tear, air fluid exchange, and put some gas. And that's how the surgery ended. And just to show in the post-op, the eye looked like this. The retina was attached. We did wide field photography as best as he could to show the eye recovered well. This boy now he has a intraocular fixated IOL lens. I put that a few years later, and he's doing very well. He has like 20/80 vision because he had some drag into his macula. Unfortunately, I think it was due to the incomplete removal of the posterior hyaloid in the first surgery that I thought maybe it was too risky, right? So that's what I had to show. And please let me hear from you guys if you would do anything different.
Well,
Yeah,
great case, great case. Congratulations, Oswald. Was really amazing case. I think when you see it, you never forget, even in lives like that. That's a really big friend, Barry. And you are right. You did a good job, and you were courageous because I don't know. Sometimes this guy gets choroidal hemorrhage and things like that, and with hypotony, and it was very well done. Very well done. Did you consider silicone oil in this case?
I thought it was not necessary, Andrea, because for two reasons, actually. One, because the retina was fully attached, and the only tear was nasal to the optic nerve, and they could surround it with laser with an attached retina. And the second reason is that if I had silicone oil in that case in a aphakic eye and the silicone oil filling the anterior chamber, we could be in trouble. The silicone oil in the anterior chamber is always bad. There was no place like for an inferior iridectomy. He had no not iris all around, so it would certainly fill the anterior chamber. It could raise the intraocular pressure. So I did gas, asked him to stay quiet as he could. And fortunately for all of us, he did well.
Yeah, congratulations. Great case.
Osvaldo,
Thank you, my friend.
and of course we worry about the cornea thing, but even if you did not, do a graft or transplantation, or maybe he has not any indication, but you get 20/80, it's already very good. So
Yes, and the reason, why he got 20/80, it's because of his macula. He got even though in the beginning, when you see the surgery, the macula is really good. In the post-op, he started to develop an epiretinal membrane, and it was really quick. But I thought I would need more time for the eye to heal before I would remove. So I only removed the retinal membrane when I put an IOL. So he's 28. He has some distortion from the cornea, of course. Uh, but for the case, I think it was a pretty good result, more than I would expect. When we went into the surgery, my assistant, and she looked at the eye and she said, "You know what you're going to do? Remove the eye?" And I said, "No, let's try to save the eye first." And so That's how it went.
Yeah, the patient might see you as a hero because this is really tough, you know.
Thank you.
Well, I think it's I think this is a miraculous result. I mean, this was a huge rupture, and to get 20/80 vision is great. And I think we all say, should we have done more? Should we have done less? I think one of the things for surgeries is knowing when to stop, and certainly if you got more aggressive with the posterior hyaloid during the first surgery, then you got a peripheral retinal break, and then went into PVR, you'd be saying, why did I, why was I so aggressive with the posterior hyaloid? So I think your decision making was spot on this, and this guy has a useful eye, and congratulations for great work.
Thank you. You know, these trauma cases, especially, they are never the same. Every trauma case is different from each other. I learned the saying from a surgeon I admire very much, a great surgeon. He once told me, you know, like in trauma, you compare a trauma eye like a broken glass. First, you pick up the pieces and you make the glass again, and then you see if you can see through it, right? So let's pick up the pieces first and then see what we're going to see.
Oh yeah, Alan, I cannot see your video. I think your camera is closed. And oh yeah,
Yeah, I went off camera for a little bit. I'll be on and off camera here.
okay, no problem.
I'm dog sitting now.
Yeah, just one another consideration about this case because Andreas and Marcelo, I know they have experience in you as well in methotrexate. In this case, Oswald, have you ever thought of using methotrexate in this case for avoiding any inflammations and other postoperative
I,
complications?
I didn't at the time. You know, this case was, it has been a few years now. It was before methotrexate became so popular. But even today, I would be, you know, like a little bit cautious about using methotrexate. It's a young boy, you know. The eye was really hypotenuse in the beginning of the post-op, so you mean like injecting every week on that eye, big rupture of the globe. So I would not, you know, like I don't know, maybe, but if you looking at the development of the upper retinal membrane, but I'm not sure, Hudson. It's one of those cases without answer, right? From
Yeah,
my point of
I
view.
know, but yeah, it turns.
But it's a great point
Yeah.
question.
Also, you solved the problem. As I said, you are the hero. So I want to welcome Ashraya Nayaka from India. Ashraya, you live in Mumbai?
No, I live in a city called Coimbatore, sir, in south of India.
South of India, yeah. Okay, so it's around 7 a.m. now for you?
7:37 actually.
Oh, yeah. So just woke up. And so we are in different zones. So it's very interesting here. And Andres in Chile, Marcelo in Bolivia. So I think Marcelo is 1 hour back. Uh,
Right.
like Chile, I don't know. Chile is the same time here in Brazil, no, Andreas?
Yes, indeed. Yeah.
So just want to welcome Ashraya Nayaka because Ashraya already participated with us in some Retinawesome meetings. And I know Ashraya has plenty of very interesting cases. The first time I saw one of his cases was in Pen Ophthalmologica, and then I said, Vibhav Seti. So please tell me, who is Ashraya Nayaka? This is the guy. So thank you for always sharing with us your interesting cases. And anyways, you have your case handy for displaying, Ashraya.
Yeah, yeah, I have it. Should I share it, sir?
Yeah, let me just put you as the co-host over here. Just a second. Yeah, ready.
Can you see my screen, sir?
Yeah, pretty well.
Yeah. Just check if the audio is coming clean.
We present multi-staged approach
Is the audio coming, sir?
Yes.
Yeah.
for post-traumatic closed funnel retinal detachment and
The video has a voiceover.
present multi-staged approach for post-traumatic closed funnel retinal detachment and subsequent full-thickness macular hole. A 51-year-old male.
Have you listening to the voiceover in the video?
Yeah, video is okay. I'm seeing the
No,
video.
there is a voiceover. Is it audible? The voiceover in the video?
Oh, yes, the sound is good. Yeah.
Okay.
Presented with decreased vision in the right eye for 15 days. He had blunt ocular trauma 15 days back with primary open globe injury done at a different hospital. He denied perception of light 10 out of 10 times. Anterior chamber showed total hyphema and conjunctival congestion. B-scan showed dense vitreous hemorrhage and closed funnel retinal detachment. Right eye post-traumatic total hyphema with vitreous hemorrhage and closed funnel retinal detachment was diagnosed. Patient was planned for surgery. Nil visual prognosis and chances of abandoning the procedure was explained. The position of the infusion cannula within the vitreous cavity was confirmed after clearing the hyphema. Traumatic cataractus lens was removed with pars plana vitrectomy. Dense vitreous hemorrhage adherent to the undersurface of the retinal tissue was cleared.
He's got choroidals as well.
Incarcerated retinal tissue from the open globe repair site was carefully trimmed off.
Dr. Hudson had a question?
Oh, yeah, he's got choroidals as well.
No choroidals. Only closed funnel RD.
After confirming the absence of adherent membrane, PFCL was injected to unfold and reoppose the crumbled retinal layer. Under PFCL, endolaser was applied to the retinal edges and direct PFCL silicone oil exchange was performed to avoid any chances of retinal slippage. Intraoperative image with closed funnel retinal detachment and dense vitreous hemorrhage. On postoperative day 1, the posterior pole was attached under silicone oil. At 2 weeks, the patient had diffuse vitreous cavity hemorrhage. Over next 2 months, the patient developed macular hole with retinal detachment due fibrotic membrane exerting traction. Re-PPV was planned. Silicon oil was removed. Fibrotic membrane causing retinal traction was removed with localized retinectomy. Subretinal silicone oil was carefully aspirated. Under air, brilliant blue G staining was performed. ILM peeling was done under PFCL. The ILM flap was inverted onto the macular hole. PFCL was removed and silicone oil tamponade was used. At postoperative 1 week, the vision improved to hand movement close to face with closed macular hole. Vision remained stable at 4 months follow-up. In 2024, Rizvi et al. showed that 74.3% of the eyes with no light perception regained vision better than no light perception post vitrectomy. So, vitrectomy may improve visual outcome in patients with no light perception at baseline. Agrawal et al. Studied predictive factors for final outcomes for severely traumatized eyes and showed that 33% of eyes with no light perception had improved vision post vitrectomy. Anatomically salvageable eyes need primary globe injury repair. Vitrectomy to prevent complications can be performed later. Post-traumatic retinal detachment warrants a trial of exploratory vitrectomy despite no light perception to restore anatomy, to gain some vision, to avoid painful blindness and disfiguring.
Wow, really cool case and difficult because oftentimes we see those traumatic eyes and with hyphema and probably vitreous hemorrhage all over. So many people wouldn't probably try doing anything, but you did. You even did a lot. You then you did the tint with brilliant blue and the ILM peeling and everything. So the technique, I like that technique when you use the ILM peel to cover the hole under fluorocarbon liquids. This works very well for me. I like this technique as well. And of course, we have to manage and removing those areas with retinotomy or maybe retinectomy when you do not have a very good retina. So you manage that very well. The case was tough, and but a very good, interesting case, and you've got good images as well.
Thank you, Dr. Hudson. So the principal key learning for me in all these trauma cases is to do the primary scleral tear repair really meticulously by doing the right technique for avoiding the retinal incarceration in the wound. If you could see in that case, the whole retina was incarcerated temporarily, which was dragging everything. That is what which even though I had cut the retina peripherally, the underlying choroid and caused a fibroglial proliferation and pulled it, and that's why you had a tractional macular hole. Normal macular hole have a oval or a round configuration, but tractional macular hole, even in diabetic TRDs, will have a elongated or elliptical shaped. So it is very important to cut the underlying fibrous tissue also when you have to close that macular hole. Only doing the ILM peeling will not close that macular hole. That we have to do it anyways, but you have to take care of the traction, which is consequential to the retinal incarceration because of the scleral tear repair. So while doing the scleral tear repair, you have to take that 1 mm margin so that the tissue gets stuck inside only, so that it doesn't get pulls the retina. And this patient was very persistent and asking for the surgery. I wouldn't want to dare do it also, but since I got many phone calls to try and do something for him. So I explained him if I might even abandon the surgery, and then took it up. Thankfully, by God's grace, I was able to do it. But 9 out of 10 times, I would not attempt doing such surgeries.
Yeah, and many things I was observing your surgeries, I do exactly the same. Like I like using the tip of the laser for sometimes, if necessary, very gently move the retina and even translocate it sometimes. So if you know how to use the tip of the laser of the where you use the endo laser, so you can actually move the retina, and it's very good instrument. At least I love it when it's necessary in such trauma cases like that. You manage that very well. So congratulations. And I want to ask if anybody want to comment on that, even other friends around, maybe Dr. Kalaivani, Jayakumar, or Shioami, or anybody, if you want to comment as well and participate, join us. And if not, Maybe Andreas, what do you think?
And no, my friend, well done, well managed, really complex case. I think that you did a great job. Sometimes these cases, when you do a retinectomy, sometimes the H's of the rectomy doesn't work. Sometimes because of the inflammatory response, sometimes overreacted, can develop this huge and very thick epiretinal membrane. So I think you did very well. I have only a question because, of course, when you see this retrospective, it's easier for us to do this, of course, these questions. But in a primary case, for example, the same patient with the vitreous hemorrhage, with the FEMA, and also with this closed tunnel retinal detachment, do you consider to do like IL peeling primarily? Like prophylactic peeling of the internal limited membrane?
Usually, by the whole range of cases, whole range of steps which have to do in these cases, I wouldn't consider doing an ILM peeling in the primary this thing. But if I'm very speculative of having a development of macular hole, I wouldn't hesitate to do, because this is a closed funnel RD. You will, in fact, because of your ILM, peeling itself can cause iatrogenic injury and cause macular hole, because there is no counter traction. You will use the macula. So you might actually cause macular hole by doing ILM peel in these kind of cases. So waiting and watching and doing it in a staged manner when it is really required, with not treating ILM as a vestigial organ can be helpful, is what I practice. So I, even in diabetic TRDs or in anything, I don't do in all cases. So where I feel there is a little bit of retinal contraction, maybe I would have done. In this case also, my in the retrospectively, I should have done as what I feel, but that whole surgery only took 2.5, 3 hours. So then I couldn't venture into doing one more complicated step. But otherwise, as you rightly said, we can actually prophylactically do in cases where we predict traumatic macular hole.
Amazing case, my friend. Congratulations.
Thank you, thank you, sir.
Yes, congratulations.
Beautiful work.
Really cool. And so, Marcelo, wanna go next?
Okay. Okay, let me. Mhm. Okay, can you see my presentation, my screen?
Yeah, it's there. It's
Okay.
not full screen. Yeah, now it is.
So my case is about a foreign body, intraocular bronze foreign body. And the thing was that this patient worked in a mine and got this trauma. As you can see in the video, we have where the intraocular, well, where the foreign body entered to the globe. It was just zone 3. So what we did first was a lensectomy. I mean, the lens was out of position, so we preferred to remove it first. Then we perform a vitrectomy and localize the foreign body, as you can see in the video. So we start to move it and remove it from this fibrin, and we start to levitate it. So it was a really big foreign body that We put it first in the anterior chamber, and then what we did was a corneal incision to remove it. It was really a tough case, but the problem was that the macula was a frayed macula. I mean, the foreign body impact directly to the macula, and there was no another option that put some laser around it because the lesion was really big, and there was a retinal detachment, at, as I will show you in the video. So we tried to attach the retina. We were concerned about the choroidals, but at the end, it resolves quite well. Besides the macular problem, we did retinal touch. I I also, in the post-op, use methotrexate 1,000 micrograms the first 2 months every week, the second 2 months every 15 days, and the final 2 months, I mean, totally 6 months, every month. So that's my how I work with methotrexate. So it was a tough case, and I believe it went well, since all the things that I show you guys. So that's my video. Thank you very much.
That was a huge foreign body. I never seen such a foreign body that large, you know. But you managed well. So difficult case. Congratulations. And it was difficult to remove it. And how did you get it from, posterior to anterior? It was in between, between the vitreous, so it was not difficult to move it or to remove it because, looked heavy.
Yes, maybe the smaller ones are more tricky to manage them, but a big one is where it was easier to remove it and levitate it.
Yeah, I understand. Yeah. And Ashraya, what do you think about this case? What do you make of
No,
it?
extremely well managed. Hearty congratulations. I would like to ask, is there any special technique to protect macula when you are dealing with these large foreign bodies? Because they tend to slip and fall on the macula. Do you have any tip to protect the macula to avoid any injury to the macula, or any
So many,
steps?
yes, many are using viscoelastic, no, the high density viscoelastic. Uh, but in this case, there was a hole in the macula, so there was no much macula to apply the macula. So that's I didn't put any viscoelastic around the macula, but the high density viscoelastic work very well, and I believe I work with that, and it with good results also.
I would add to the case, just to protect macula in some cases, after I have good visualization from the whole thing, I would use perfluorocarbon liquid to protect the macula in some cases. So, many foreign bodies, they come floating over the macular area. And I have a technique for removing IOLs, dislocated ones that I call stand-up technique. Whenever I put the perfluorocarbon liquid after a cool, good and overall vitrectomy, and then I use perfluorocarbon liquid, so I get the IOL, for example, just staining. So in many ways, perfluorocarbon liquids, they protect the macula. So how often you use Ashraya at your place, perfluorocarbon for that purpose, for protecting the macula?
Usually, the one thing I try to do is I didn't try and gauge the size of the size of the foreign body and make a liberal opening, because generally we make a smaller opening to bring a macula foreign body out through it, and that is why it slips out. So I, as Marcelo described, use viscoelastic also, but PFCL I'm a bit worried before. If I've already removed all the traction, then it's fine. I'll use the PFCL. If at all I have to use PFCL only to do it before removing all the vitreous, then it can migrate subretinally, which is very difficult to remove. So it based on the step I am doing. If I've already removed, then I use PFCL. Otherwise, I try and do a liberal opening to remove the foreign body. And if nothing is available and it is very difficult, then viscoelastic is a good option, as Marcelo described.
Yeah, I agree. But I was just afraid, as even though Marcelo said there was a macula hole, but I've still become afraid. This huge foreign body tearing the retina. So as long as you moved away from the macula, it's okay. Congratulations, Marcelo. Really cool.
Thank you, Hudson. Thank you.
And
Thank
now
you so
I know that André Jucá has got a series of cases, very interesting cases of trauma that he was discussing with me earlier. So, André, so what about your cases?
Yeah, thank you. I would like to thank you very much for being here again. It's very nice. Well, I would just like to comment on this very nice case of extra large foreign body. One option when you do not have a forceps that's big enough, and it's hard to have a forceps big enough sometimes, it's just to open the cornea and put the patient face down and try to remove it. Like in the old days that the guys did the surgery before perfluorocarbon. If the PFCL do not levitate the intraocular foreign body, you can just reverse the patient and just make it comes for the action of gravity for the anterior chamber, and then try to remove it with the cornea already open, of course. That's another option. But yeah, I brought some. Are you seeing my slides, Hudson?
Yes,
Yes,
yes.
Andre.
Okay.
Yeah, it's there.
Okay. So I brought some cases, of course, some cases of close and open. This the first case that I just have here is this case that here is Flamengo and Fluminense. This is a big game in Brazil, and uh, I don't know if you know, but the Mundial championship was won by Chelsea, but the only team that beat Chelsea was Flamengo. Fluminense is this guy here. It's beautiful shirts, both of them. Just get well in the champion, although they didn't win. Flamengo won the champion, 3-1 in the group phase. Was well played, Flamengo and Fluminense. But this guy here just had this commotion retina, and that's why I remember that this soccer player, a guy just hit a football, and he was playing. He was too close, and the ball hit his eye, and he has this commotion retina. Of course, he was complaining of a shadow in the inferior visual field, and he just maybe it was a retinal detachment, and they sent me that was just this commotion retina. Of course, the edema is in the center, and we had Berlin edema, but after just with some eye drops in a few weeks, the edema just recovered. This is another case that we had of a trauma. This patient just have a pellet gun, and that was shot near his eye. It was in the nose. The bullet was not inside the eye. But in the echographist just said maybe there is a rupture in the eye. And we got in anyway to remove the blood. And you can see that with the energy of the bullet, although it's a very small bullet, you have all this damage in the retina. You see the edema and everything else. Uh, we just get posterior vitreous detachment, and as you can see, there is a big hole in the retina. So it was a good thing that we decided to operate, because sometimes you may try to wait a little bit more, but it was good that we could just uh, uh, have this done and this procedure, and remove the body, the blood, and do the laser. And uh, we just, of course, there was still some blood coming from choroid, and we just decided to keep the eye with silicone oil to avoid this blood uh, uh, increasing. And there was some subretinal blood, but not a lot in the macula, so we didn't try to remove it. This is another case. It's from a kid, and with kids, it's always we are never sure, because he said there was a pencil that perforated the eye, but I thought it was perhaps not a pencil, because the incision was really too perfect. It looked like a blade did that. And I said, maybe there is something inside the eye. That's going to see if there is something inside the eye. There was a vitreal hemorrhage, and the echographer was not sure if there was intraocular foreign body or not. So he said, maybe let's see what's going on. There is not a lot of blood inside the eye, but again, we get this posterior vitreous detachment, and we just check the eye, and as you can see, there was not um, much big damage in the retina. There was nothing in the retina, and although there was some impact uh, in the eye, and there was vitreal hemorrhages. This case, maybe in retrospective, maybe we should wait a little bit and not do the vitrectomy, because the blood could reabsorb with time. So sometimes ecography helps, sometimes they're not very sure. And the history with children is very difficult to be sure of what they're telling about. Because sometimes they're not telling the whole history, they're afraid of being punished for something. So with kids, it's always, and we tend to do a little bit more when we are not sure, isn't it? We put just air. This is another case that we have this corneal flap displacement during in trauma surgery. This was a festival, São João Festival here in Brazil. We just had one a few weeks ago, and this lady was passing by, and the guy was shouting to drop some toys, and she got hit by this shotgun in the eye, and but it was not uh, the the bullet. It was not in the eye, just it got through the eye, and we were just trying to remove the epithelium, but uh, we are not trying to clear a little bit the cornea, and then oh, she got a LASIK flap. Well, it's good because now cornea is much clearer. So this helped us in removing all the blood and lens material and everything that she got on. So was not a very easy surgery, because even with the flap removal, although the vision was a doable case, it was not the best vision that we had. So we just remove all the blood that we could. You see that the iris is very damaged. We did in another time an artificial iris in this patient and put a secondary implant intraocular lens. But in this case, we decided just to put the gas, free 63 F8 gas, and the patient did well. Nowadays, she got after uh, she ended up with, although we put back the flap and everything, but the flap really never cleared, because the synergetic energy of the bullets just burned the cornea. and here is the cornea is opaque. And the last case is this guy that have intraocular foreign body. He was working in he's a mechanic and was trying to repair a car, and a piece of the metal just got inside his eye, and you see here that the crystalline lens is perforated the posterior capsule, and here is the metal intraocular foreign body, and we couldn't see anything. There was suspicions of endophthalmitis, and we did this surgery, beginning with the corneal suture, and then we removed the lens. This is about 3 days after the trauma, so the patient gets some time to get to us, and of course, it's not very good because the infection, of course, is going to progress. Although the eye is not very hot, there is not many signs of inflammation, but in the vitrectomy, we are suspicious that may have an inflammation, and we decided to go on and remove as fast as possible the intraocular foreign body. We use a magnet because it was a metal, to remove it because the retina was very ischemic and more damage to the retina for the falling of the foreign body. And we just try to, you have to put the intraocular foreign body in the same direction of course, to remove it for a small incision. And then we did this laser because we thought maybe this guy is going to get a neovascular glaucoma, so ischemic. But after the surgery, the circulation just recovered after we remove all the toxins and everything. We did antibiotics. This is viscoat coming out. We decided to put an intraocular lens in the first time. This is the corneal scarring. So it's yeah, this is some cases that I brought from day to day. Some are easy and not to operate, others are hard to operate, and some you have to do in a multi-step procedure. Thank you very much again, my friend.
Really interesting cases, André Jucá. I would choose the one from the São João, St. John party the best, because intraoperatively the retina looked so good after the time we were at the time we were doing laser. So the retina was very good looking. And you said that the cornea had some opacity. Does she has an outcome for a graft?
Yeah, we hoped that since we repositioned the flap, we hoped that the transparency of the flap would come back. But the cornea was really opaque and it never really clear. So the patient gets a corneal graft, a new corneal graft, and at the same time we put an artificial iris with an intraocular lens, and the patient did well. She did get a macular hole, a very small, a tiny macular hole, that after some weeks it closed by itself, as it usually happens in small traumatic macular holes without any tractions. So there was also this thing. So the thing is in trauma is when to operate, how much to do, and everything is difficult in trauma because every case is different. So we have to decide at the moment of the surgery.
Of course. And Osvaldo, what did you make of the excellent cases from
André is always brilliant. I would like to ask a question. How often do you use intravitreal antibiotics when you have intraocular foreign bodies? What's your view about that?
Yeah, I always do. I put the antibiotics in the BSS because the dilution is very hard to get it right. So I put it, but we know that when it's a bullet, it's not the chance of getting infection is much smaller because it comes so hot that every bug is killed. But when it's an intraocular foreign body that a mechanic is working on, in this case, is almost sure that he's going to get an infection because there's no this, and how long it stays also makes a difference. So with intraocular foreign body, we must do the surgery as fast as possible, as you know that. But I put ceftazidime and vancomycin because I do not have the courage of putting amicacin. It's too complicated. Because if you're going to put silicone oil, and then you don't know anymore, because even if you put a small amount, it can concentrate and cause it be toxic for the retina. So to avoid that, we put in the BSS. And if a small amount of BSS is still in the eye, it's going to be effective.
Congratulations again. And I want to proceed with Andreas' case, if you have it.
Yes, one sec, my friend. I will share my screen. One second, I have it here. I don't, let me know if you can see it.
Yeah, it is there.
Okay, let me put in. Okay, so so your cases have been so challenging, complicated, and so well managed that my case will be like a children's story in comparison with your cases. When Hudson invited me, I had presented this case, the same case, at my hospital in the monthly meeting. And the opinions were divided between the retinologists and the other ophthalmologists to regards the origin of the trauma, and I will show you, and also the time evolution, because the patient was complaining about like 2 or maybe 3 weeks after the trauma. But in the retinography and with the pre-op images, we found some changes that make us question, is there something else? It was a consequence of the trauma, or it was something that was before in the retina, and this helps to the retina to detach because of this trauma. So this is a male patient, is only eye. So the chief complaint is a 3-week history of a blunt ocular trauma secondary to an assault. So the patient complains about a progressive decline in vision over the past weeks in the right eye. The patient didn't have like immediate medical attention because the patient was in the south of Chile, and we don't have too many retina specialists in that area in my country. So the public service sent us this patient to resolve it almost 3 weeks later. Okay. So the best corrected visual acuity in the first consultation was had movement. The other one was no light perception. The IOP was 8, and the patient has a normal, like orbital cerebral bone study. So we have these pictures of the patients. So this image reveal retinal fissures, you can see, that raise several like important clinical questions. For example, is reported evolution time of 2 or 3 weeks, and 2 or 3 weeks are compatible with these findings, such a retinal cyst, as we can see in the mid periphery of the retina. We can see also some PBR and in the inferior part of the retina, and also there is kind of a vitreous haze, or the vitreous kind of sticky. So that's the first questions. Or those things suggest I like a chronic retinal detachment? Was 2 through 3 weeks? Was something that was before? Maybe some underlying congenital or infantile vitreoretinal pathology that was under this trauma. And maybe that's the reason why the other eye was also blind, why this patient is only one eye. And we don't have any questions. I mean, we don't have any informations to regards the left eye, what happened. So that's the first question that I want to develop with you guys. So we have here this tear superiorly, we have the cyst in the middle periphery, we have this retinal detachment macula off. So in this case, we decide to do phacoidal scleral buckle, a posterior vitrectomy laser, and try to use silicone oil and intravitreal methotrexate. So we start doing the scleral bucket. What is scleral bucket in this case? For example, I decided to do it because the proliferative retinopathy was not too very extensive, and I did not anticipate significant anatomical distortion or need to do a retinectomy. And the patient has a lot of different lesions in the periphery, so I think it was a good idea, a good plan to put a scleral bucket. We found this submacular hemorrhage. I don't know, I did it because of the scleral bucket, or it was before. We didn't find underlying choroidal fractures. So, but the vitreous was it was from pigment. We do a complete posterior vitreous attachment. Then to make sure that we do a good vitrectomy, even in the we use transitional just to make deeper that we did well. We have to do something with that. As you can see, there was super rigid in that part. Using the ILM forces, we just create a small adenectomy, and from that we using the soft dip, we just drain the submacular hemorrhage. Then in this case, after we drain the submacular hemorrhage, we use PVCO. I always use, or I like to use always PVCO to stabilize the posterior pole, and do laser. In this case, we try to do like a 360 degrees PRP, and when well, we have some issues at the end to complete, even do it indentation, the anterior edge of the principal tear, but then we completed very well. And after that, I did the exchange with the PVCO silicone oil, and the patient thankfully went well with improving the vision until 0.1 and good IOP.
Did you create a small retinotomy to remove the hemorrhage?
Um, yes, but it was so close to the macula that I was kind of scared to make a bigger hole close to the fovea. So that's why I was like, okay, I will try just to use only the IOL forceps, try not to burn near to the fovea. That's why I decided to use only the forceps and not to do a retinectomy, for example, with endocauterio or with a laser. That was my thought in that case. And the patient thankfully went well. The retina was attached with, of course, chronic change. And my questions are, what do you think, guys, to regards this cyst in the retina? How do you will manage? Do you like to use, for example, scleral bucket in retinal detachment secondary to trauma?
Yeah, I think you managed the case well. I don't know if I would just observe after this treatment you did vitrectomy already. I don't know. What do you think, Ashraya? Would you do anything uh, different or more?
I think extremely well managed case. Congratulations, Dr. Andreas. Uh, I would actually take an history more why he lost the other eye, because is it syndromic is what I would like to see if there is anything else at play. But other than that, if you can see, look at those cysts formed, it is not 3 weeks old. It is definitely, it would take more time to develop, and the detachment was more inferior. So that's why patient was not complaining. So once I'm inside the eye, I would. One thing I want to make sure is definitely get rid of the cortical vitreous. So after doing triamcinolone acetonide staining of the vitreous, I would even go and try and do a staining with a brilliant blue to see the cortical vitreous is not there, because that is the one of the main causes for recurrent RDs in these cases. And when there is such a bullous RD, when you are trying to manage, like you are definitely more skilled, so you could manage. I would definitely use PFCL to a large extent to keep it unnecessarily fluttering and getting into the cutter's mouth and cause some iatrogenic breaks. So once I am done with that, then I would do in this such bullous RDs. If the traction is all relieved, fine, then I'll do a PFCL air exchange. Otherwise, I will do a PFCL silicone oil exchange, and would not like to go and do anything near the macula. As I told you earlier, also, I would leave it for the second stage if there is anything to be done.
Can I make a comment?
Sure, go ahead, Zach.
Yes, great case. Congratulations. Beautiful surgery. Beautiful case, actually. Did you do any genetic testing in this case? Do you think it can be some kind of possible X-linked congenital retinoschisis with chronic retinal detachment, something that, like developed through time, something like that?
We send the patient, but of a matter of money and resources, the patient, because the patient was a very like a complicated economical situation or social situation, he couldn't do the genetic test. But if you ask me what I think that the patient, I think that the time that the patient was referred, like these 2 or 3 weeks, because of the features of the retina, I think it's more like a chronic retinal detachment, secondary to maybe an old trauma. I don't know, more than maybe a retinoschisis or an infantile or congenital vitreoretinopathy. It will be nice, maybe, but we couldn't have the information from to regarding the left eye because he was only one eye. But it would be nice to see if there is any more information to see was something genital, congenital, or
Yeah, we lost the last comment, last phrase, because the connection didn't go through.
I'm
Yeah.
sorry. So yeah, will be nice, will be ideal to have more information regarding like genetics or some another like relative of this patient, but we couldn't have more information. I mean, the patient is doing well, but the social situation of this patient coming from the south is very difficult to them to be able to do this genetic test that are not covered in the social service, and they have to do it by themselves, and it's very expensive. But yeah, but it would be nice to have a genetic test, definitely.
All right. Any more questions on the case? So I think, is there anybody else to present? So I think I'm going to show my case. Can you see it?
Yeah.
Yes, inverted vitrectomy.
Oh, yeah. So let me start this case. And this is an interesting case of the patient had a trauma. And so after those traumas that get an outcome switch, we got this giant retinal tear in a patient that had the trauma. This is the B scan, and the trauma was perforating and also a blunt trauma. the patient had these corneal sutures, as you see here, pretty well managed by the emergency department. And after a while, after actually a month, so the patient was sent with a retinal detachment, and you see this very giant retinal tear was folded a little bit on its edges with some PVR. Also, so I decided to do a core vitrectomy, and since we had some shortening, as you see here, vitreous very engaged subretinally and pulling on the retina itself. So you see the difference in colors from the healthy retina and the PVR retina. And the visualization system is very good, that we see all the periphery. So the retina was starting to get mobile. So I decided to observe the very retinal periphery and enlarge a little bit the retinotomy where it was most tractional. And even though we had these corneal sutures, the visualization was very good. So I'm here enlarging a little bit the retinal periphery to make it more mobile. And now you see the retina completely mobile, but folded on itself. So folded on the macula. Now, you see these visualization systems, the corneal sutures don't make much of a difference. So you do the vitrectomy with a very good view. Now, using the perfluorocarbon liquid, I'm opening the funnel-like thing here, this part of the retina going up and freeing up the macula, as you see, very slowly. And the patient actually had a very good outcome. If you see here, the retina now completely attached. It looked a little bit similar to that one case that you showed earlier. And here at the very periphery, doing laser to protect the retina around. And of course, the retina now is very flat. I used a little bit more of the fluorocarbon liquid so that I could go further to the periphery. Now I'm putting a little more fluorocarbon liquid and doing laser all around the retina. Coming to the end of the case here, but before doing the barrier laser as much as possible to make the retina periphery protected. And of course, in this case, we did not have a choice. We had to use silicone oil. Now more peripheral laser, a lot more peripheral laser. The laser took very well, caused this scar like thing and barrier of protection around. And I'm doing this direct exchange, as you see here, through the cannula, silicone oil coming in, so removing some air bubbles, and now I'm going straight towards the posterior pole and dipping into the perfluorocarbon to remove it at the same time as I inject silicone oil. So you see the bubble getting shrinking, and you get the up to the last droplet. It's good that you don't leave anything there. And the macula looked pretty good. The retina, in this case, got completely attached. The patient is attached with silicone oil, and it's not programmed to be removed by now, but soon. That was a really switch of an outcome, because if we left those folded retinal in itself and PVR and giant retinal tear, of course it would be a lot worse by today. So really interesting case that I wanted to show you guys.
It's a great case, and I think the one thing that you did that's really good that some young surgeons don't do is you were very patient with the perfluorocarbon with the PFCL is oftentimes I'll put a little in and um, do some laser like you did, and then put a little bit more PFCL in, and the retina just will slowly relax if you give it time, and it'll flatten easier. So um, I think that was really nice how you did that.
Yeah, thank you. I like doing that, Alan, because as you do the direct exchange, in this case, very slowly, so you do not give a chance for the retina to move around, to dislocate, to rotate, and not to coincide with the vessels where the retina was attached before. So I like doing that very slowly in very many cases. And of course, if I need to use silicone oil in not all cases, I do direct exchange. Sometimes I go through air. It's easier, of course, but if the macula is on, that is not a problem on that. But for the direct exchange, like I did in this case, that's my favorite technique. Yeah, that worked well.
Yeah, you avoid the posterior slippage during the direct uh, exchange, direct silicon, perfluorocarbon silicon oil. One thing that worries me always in this case is the removal of the anterior flap, because we know that you can get a nice retina attached in a hypotonous eye due to the anterior proliferations. So I do pay attention to remove all the anterior flap of the dead retina that was killed, and I'm sure you did it. But was really nice, recorded, a very beautiful year. The image was excellent quality. Congratulations, Ruth.
Thanks. And even though we had this corneal opacity, but the wide angle vitrectomy viewing systems allow us to see through those defects. And I like very much using after I do the peripheral and the core vitrectomy. And then I like to move to the macular lens as soon as possible to get these good images. Anyways, you might need to do an ILMP or anything like that. So I like to see more. And also, as you pointed out, we have to remove all tractions. We have to remove, if possible and if necessary, to relieve the retina tractions. And I love doing these uh, direct exchange, but also I start at the very periphery, not to have any slippage of the perfluorocarbon liquid. And of course, after I saw the retina was pretty flat, and I completed a little more with a little more of perfluorocarbon liquid, so I could observe the retina at the very periphery. And then I started doing the direct I mean the perfluorocarbon silicon oil exchange. So I started at the very periphery to avoid the perfluorocarbon liquid from coming, subretinally. So this is something that we usually tell the fellows to observe, and that's why wide-angle systems they help a lot.
Okay.
Great case, Dr. Hudson. Extremely beautiful to see the retina unfold. I just want to highlight the steps which you did. Of course, in GRT, most of the cases we do have a little bit of PVD which helps. But what really makes it very challenging is the extension of this posterior vitreous detachment to up to the periphery beyond the break itself. So that is what you did it very meticulously to shave off all the vitreous so that it doesn't really cause any secondary recurrences. So another important point was when we are injecting PFCL, usually if we have not kept the infusion off, the intraocular pressure might itself hinder the formation of a big PFCL bubble and cause little droplets to form. So the few people also use a double bore flute needle to avoid that pressure differential. Otherwise, if we have too many droplets in the periphery, of course, you took great care so that it doesn't migrate subretinally. But otherwise, these small droplets, when you're doing PFCL oil exchange, can migrate subretinally and just can such a beautiful macula can have a PFCL bubble under the macula. So you might avoid that by taking care of these two steps. And when you have a 360-degree GRT, off late I have also started using up a short-term tamponade of PFCL. You don't do exchange that time. You do a laser, leave the PFCL, fill it up to the brim, and leave it for 3 weeks or 4 weeks till the laser retinopexy comes into play. And we have extensive studies these days published on the short-term tamponade. And once the retina is attached, then just do a PFCL layer and silicone oil exchange if needed, or just do a gas tamponade and leave it. Otherwise, extremely well managed case, and there is a lot to learn from this case. If I may ask, what imaging system do you use, and how do you prevent fogging in these cases?
Oh yeah, I use the Ingenuity system. And so I like using the contact lens system so that I use a very good lens for peripheral visualization. In this case, I use the Volk lens, is 160 degrees. It goes all retinal periphery. And the good tip that you mentioned, I usually, before injecting perfluorocarbon liquid, I usually put the pressure down, like it was usually 30, so I bring it down to 20. So I avoid some bubbles, even though some bubbles they come. So I wait for them to coalesce and do and create one single bubble. And another tip that you mentioned, very interesting to leave the PFC there, except that I don't like very much to leave the PFC because, and then I have to come too fast a month later to bring the patient back. And many of those patients we operate in the public system, so they don't have too many chances of doing surgery, just right away. So in this case, the tip that I suggest for the residents and fellows is, especially fellows, to do the vitrectomy is to do a very slow direct perfluorocarbon silicone exchange, looking at the very periphery just in case some perfluorocarbon liquid comes in, but soon after surgery, you put the patient facing down, and of course, some of the perfluorocarbon, if you leave any, so they are gonna come up the next postoperative day low in the inferior part of retina. So if it was a little subretinally at the very periphery after surgery, if you put the patient facing down, so this perfluorocarbon liquid will just slip towards the vitreous cavity. So this is a tip. And of course, we don't want any PFC at all. But if that happens and if you want to avoid, I think positioning is very good in these cases that you have retinotomies and large retinal tears.
And I just want to tell the youngsters about the two important things which you did in the case. One is the last bubble, when you're aspirating, you used eye magnification. That eye magnification helps you to actually visualize the bubble quantity. Otherwise, you will cause a retinotomy there. So that was extremely good technique. Another thing is you also preserved the anterior capsule. You didn't cut the whole capsule. You just removed the central fibrotic band. So after the in the back, the sulcus is the next best place for the IOL to be in place. So preserving the anterior capsule rim is also equally important. You can do a lensectomy, but if you preserve the anterior capsule rim, it will definitely help you to place the IOL once you do the silicone oil after 3 months or 6 months, depending on the case. So, hearty congratulations on the case.
Thanks. And I also preserved, of course, waiting for the secondary IOL later, but we removed this just the centers just to make the image better, and that was the case. And thanks a lot. And anybody wants to make any comment on this case or any other case that we presented? I think that was really nice, and we had such interesting cases. And I want to just show you. I'm a member of the French Academy of Surgery, and we had Dr. Moron here just behind me in blue. He was invited from the French Academy of Surgery that we participated a month ago to talk about physics. He won the Nobel Prize in physics for France. So his study and his works were on femtosecond. So we are attached also to the French Academy of Surgery. And I also want to thank Media Mice for helping us to show and display our work and our interactions worldwide. And this presentation will also be displayed inside the French Academy, also our websites and Retinawesome. And you feel free to share again your great cases. I want to thank you and every one of you that presented the cases. And Osvaldo, do you want to say anything to close the session?
Just congratulate you for, like joining us here and giving us the opportunity to see very nice cases from all around the world. So it was a great night, great evening for us in Brazil, and morning for you guys in the other side of the world. So have a great day. We're going to sleep now. So
Yeah, it's 16
okay.
past midnight over here, but it's a good time that.
Have to work tomorrow. So
Yeah, I know, I know. I think Ella Franklin is a little bit earlier, probably 4 hours back. It's
I'm Central Time, so I think I'm 2 hours back.
2 hours, okay. That's fine. And thank you very much again for this excellent session. And thanks also the audience that participated. And Robinson and Dr. Kalavani, Shio Emi, Shio Emi was the first one that arrived here tonight. Thank you very much again. And see you in the next session. See you, Marcelo.
Thank you.
Thank you,
See you.
Dr.
See you.
Thank you.
thank you,
Thank you
Hudson.
so much.
Have a great
Thank you.
Thank you very much.
Thank
Bye bye.
thank you, Edson.
Bye bye.
Bye
Bye
bye.
bye.